So I want you to picture a 17th century doctor or
Yeah.
just standing in this dim candlelit room trying to physically pump the blood of a live sheep into a human patient.
I mean, it sounds like a horror movie.
It really does. And it was absolute unmitigated chaos. I mean, the results were exactly as disastrous as you would imagine.
Right, yeah.
But contrast that horrifying image with today. Because when you think of modern nursing, there is this expectation of absolute unbending precision. It's like an assembly line of safety. You know, barcode scanners, exact milligram dosages, double-locked medication cabinets. Everything is just highly, highly controlled.
Oh, absolutely. And it's a system designed entirely around eliminating variables because, we crave predictability in medicine, especially when we're dealing with something as volatile as human biology.
Exactly.
The early days of transfusion were quite literally a shot in the dark. They didn't even fully grasp what the fluid they were transferring actually contained.
And that terrifying contrast is the mission of today's deep dive into our sources. We are taking a really comprehensive look at the modern science of blood transfusion.
Yeah, it's a huge topic.
It is. Specifically, we're unpacking the safety protocols, the severe physical reactions, and the absolute non-negotiable rules for the nurses administering it. Because this isn't just like a routine hospital checklist for you to fill out.
No, definitely not.
It is a high-stakes, risk-bearing treatment. A nurse's vigilance at the bedside is the literal difference between life and death.
And it requires that level of vigilance because, on the surface, a blood transfusion sounds deceptively simple.
Right, like a plumbing fix.
Exactly. You have a leaky system or an empty tank, and you just put fluid back into it to bring the pressure up. But the reality is that transfusion is a really complex, constantly shifting science. We're transplanting liquid tissue from one human being to another.
Liquid tissue. That's a crazy way to think about it.
But that's what it is. And the rules of what we give, when we give it, and how we monitor the body's reaction to it, they've radically evolved.
So to really grasp those modern rules, we sort of have to look at how we even figured out what blood, is. Because for the longest time, a transfusion just meant take blood from person A, put it into person B, and cross your fingers.
Yeah, and the foundational breakthrough there didn't even happen until the turn of the 20th century.
Really? That late?
Yeah, in 1900 and 1901. There was an Austrian physician named Karl Landsteiner, and he was mixing serum and red cells from his colleagues in a lab.
Just casually mixing his coworker's blood.
Basically, yes. And he noticed that certain combinations caused the blood to clump up or agglutinate. It was essentially turning into a thick sludge.
Oh, wow.
Right. And that single observation led him to discover the distinct blood groups we now know as A, B, and O. And then his colleagues identified the AB group shortly after, in 1902.
Which finally explained why some of those early desperate transfusions miraculously saved the patient, while others killed them almost instantly.
Exactly.
The blood was literally clumping up inside their veins.
It was a monumental discovery. But the tragedy of foundational science is that the recognition often lags decades behind the application. Landsteiner didn't win the Nobel Prize for this until 1930.
Wait, nearly 30 years later?
Yep, nearly 30 years.
That is wild. But okay, even with the blood types figured out, the physical logistics of moving blood from one body to another, it just sounds like a surgical nightmare back then.
Oh, it was incredibly grueling. So around 1906 and 1907, an American surgeon named George Cryle was performing direct artery-to-vein transfusions.
Direct, like no tubes or bags.
Well, you couldn't just use a needle in a bag. You had to physically slice open the blood vessels of the donor and the recipient and stitch or clamp them together with tubing.
Oh my God.
Yeah. It required extreme surgical skill. You couldn't really measure how much blood was actually being transferred, and it was really only viable in the absolute most desperate emergencies.
Just two people literally tethered together in a surgical theater. I mean, that is not a sustainable medical practice.
No, not at all. The real game changer, the thing that actually made modern blood banking possible, happened in 1914.
Okay, what happened then?
Two physicians, Luis Agode in Argentina and Albert Huston in Belgium, independently figured out a chemical workaround.
Oh, okay.
They realized that if you add sodium citrate to blood as it leaves the body, it prevents it from clotting.
How does that actually work, though? Does it, freeze the cells or something?
It's all about calcium. So the human body's clotting cascade relies heavily on calcium to form those biological nets that stop bleeding.
Right.
Sodium citrate binds to the calcium in the extracted blood. It essentially locks it up so the blood can't clot. Suddenly, you didn't need the donor in the room
You
anymore.
had a chemical pause button,
Exactly. You could store the blood in a glass bottle and use it days later.
which obviously changes the entire landscape of global medicine, especially with the world wars kicking off right around then.
Definitely. World War I saw the first organized use of stored blood on the battlefield by Oswald Robertson. And then World War II drove this massive institutionalization of the field.
Okay.
Charles Drew, who was an African-American surgeon and researcher, he developed large-scale methods for processing and storing blood plasma. He directed the massive Blood for Britain program in the early 1940s, and he really helped structure the American Red Cross's blood banking system.
Let me pause on that for a second, because our sources highlight a massive shift in how we actually deliver this blood today.
Right.
Because back on those battlefields, they were giving people whole blood, literally everything that came out of the donor's arm. But if you or I end up in the hospital today after a car crash, we aren't getting whole blood, are we?
In civilian medicine, almost never.
Wow, okay.
And that represents a fundamental shift in our definition of a transfusion. Today, when we say blood transfusion, it almost universally means component therapy.
So they break it down.
Yeah. When you donate a pint of whole blood, the lab spins it down in a massive centrifuge. They separate it into its parts. Packed red blood cells, fresh frozen plasma, platelets, and cryoprecipitate.
So it's more like a customized biological recipe. Like if I'm bleeding out, I might get red cells for oxygen, plasma for volume, and platelets for clotting, but they're all coming from different bags.
Exactly. Whole blood is mostly reserved for military trauma medicine out in the field and, some very specific pediatric cardiac surgeries.
Oh, interesting.
Yeah. Though I will say there is a bit of a current revival in researching low titer O whole blood for severe pre-hospital hemorrhage. But generally, component therapy remains the absolute default.
Yeah.
We give the patient only the specific part of the blood they are missing.
That makes a lot of sense from an efficiency standpoint. But the sources point out another massive shift, and this one is about when we decide a patient actually needs that blood.
This is a huge one. For most of the 20th century, the medical culture was incredibly liberal with blood.
Yeah.
The operating assumption was basically, when in doubt, transfuse. Doctors wanted to keep a sick patient's hemoglobin levels really high, usually near 10 grams per deciliter.
Because intuitively, I mean, if you are sick or injured, having a full tank of oxygen-carrying red blood cells just feels like it would help you heal faster.
It feels incredibly intuitive. But, biology rarely cares about our intuition.
Fair enough.
In 1999, there was a landmark study published in the New England Journal of Medicine called the CHIRI-CEC trial, and it completely upended this logic.
What did it find?
Well, it compared that liberal strategy to a restrictive strategy, where doctors forced themselves to wait. They only transfused when a stable patient's hemoglobin dropped all the way down to 7 grams per deciliter.
That sounds incredibly risky, like letting a patient get that anemic before intervening.
The results were staggering, though. The restrictive strategy proved that giving less blood produced equal or sometimes significantly better outcomes for the patients.
Wait, better outcomes by withholding a treatment? Why?
Because a transfusion is essentially a liquid organ transplant.
Oh, right. You said that earlier.
Right. When you infuse foreign biological tissue into a sick patient, you are introducing a massive inflammatory and immune burden. It causes immunomodulation, meaning it can actually suppress the patient's own immune system, which increases the risk of infection.
Wow.
It also risks volume overload, which stresses the heart. The CHIRI-CEC trial forced the medical community to realize that blood is a risk-bearing treatment, not just some harmless tonic. Today, that restrictive threshold fundamentally dictates how a nurse interprets a patient's lab results.
So if we are injecting foreign tissue that carries that much inflammatory risk, the biological matching process has to be, flawless.
It's absolutely flawless.
Let me try an analogy here to unpack the biology of compatibility, because antigens and antibodies can get pretty abstract quickly.
Let's hear it.
Okay, imagine the antigens on the surface of your red blood cells are like a team uniform. You're wearing an A uniform or a B uniform. And the antibodies floating around in your blood plasma, the liquid part, are like bouncers at a very exclusive club.
That's actually a highly accurate way to visualize it. The antigens are the physical identifiers, and the antibodies are the immune system's security force.
So if you have type A blood, you're wearing the A uniform. Your plasma has anti-B bouncers constantly on patrol.
Correct.
If a red blood cell wearing a B uniform gets infused into your bloodstream, those anti-B bouncers are going to aggressively attack it.
And they don't just, escort it out, they destroy it entirely.
Jeez.
The medical term for that destruction is hemolysis. The recipient's bouncer antibodies latch onto the incompatible donor cells and literally rupture the cell membranes.
And what does that physical destruction actually do to the patient lying in the hospital bed?
It triggers a systemic catastrophe. When those millions of red cells rupture simultaneously, they dump their contents, specifically free hemoglobin, directly into the bloodstream.
And that's bad.
Very bad. Inside a cell, hemoglobin carries oxygen. But free-floating in the blood, it is incredibly toxic.
Oh, wow.
It travels to the kidneys and physically clogs the delicate renal tubules, causing sudden acute kidney failure. Furthermore, all that massive cellular debris activates the body's clotting cascades inappropriately.
Wait, so the blood starts clotting everywhere?
Exactly. It leads to a condition called disseminated intravascular coagulation, or DIC. The body forms microscopic clots in all the small blood vessels, which consumes all your clotting factors, meaning you simultaneously start bleeding uncontrollably from everywhere else.
That is horrific, clotting and bleeding at the same time.
It triggers systemic shock, and this entire cascade can be fatal within minutes of the incompatible blood hitting the patient's vein.
Within minutes, that is terrifying. And that's just the ABO uniform system, right? The sources also heavily emphasize the RH factor.
Right, the RH factor, which is the positive or negative attached to your blood type. About 85% of people carry the RHD antigen on their cells. They are Rh positive. The remaining 15% are Rh negative. But the Rh system behaves completely differently than the ABO system. If you are Rh negative, you don't naturally have anti-Rh bouncers already patrolling your blood from birth.
Oh, really? So if I'm Rh negative and I accidentally get infused with Rh positive blood, my immune system won't attack it right away.
You get a free pass on the first exposure.
A free pass.
Sort of. You can receive that one Rh positive transfusion without an immediate hemolytic catastrophe. But that exposure teaches your immune system to recognize the foreign antigen. It essentially prints wanted posters and builds an army of anti-Rh antibodies.
So the trap is set for the second time.
Exactly. If you ever get a second exposure to Rh-positive blood, that newly built army will instantly attack it, causing massive hemolysis.
Wow.
And this delayed sensitization is also the exact mechanism behind hemolytic disease of the newborn, or erythroblastosis fetalis.
How does that happen with a newborn? Like, how are they exposed?
So if an Rh-negative mother is carrying an Rh-positive fetus, and their blood mixes during delivery, the mother's immune system will build those anti-Rh antibodies.
Okay, I follow.
If she gets pregnant with a second Rh-positive baby, her antibodies can cross the placenta and destroy the fetus's red blood cells.
Oh my God, that's tragic.
It is, but thankfully today, we prevent this entirely by giving the mother an injection called RhoGAM during pregnancy.
RhoGAM.
Yes. It basically cloaks the fetal cells so that the mother's immune system never even sees them, preventing the antibodies from ever forming in the first place.
It's brilliant that we can, like, hijack the immune system like that.
Truly.
Okay, speaking of the immune system, I have to bring up a huge assumption I had before reading these sources. I've watched medical dramas my whole life, right?
Sure.
And the doctors are always shouting, "Get me O negative." So I just thought O negative was the universal donor for everything.
You and everyone else.
Yeah.
That is perhaps the most dangerous misconception in public medical knowledge. O negative is the universal donor for red blood cells only.
Right, because O negative red cells have no A antigens, no B antigens, and no Rh antigens. They are wearing a totally blank uniform.
Precisely. You can put those blank cells into anyone, and no bouncers will recognize them to attack. But for plasma transfusions, the rules run in the exact opposite direction.
Wait, really?
Yeah. Remember, the plasma is the liquid where the bouncer antibodies live. Because an O-negative person has a blank uniform, their body naturally produces both anti-A and anti-B bouncers to protect themselves. Their plasma is fully loaded with both sets of antibodies.
Oh, wow. If you give O-negative plasma to a type A patient, you are literally injecting an army of anti-A bouncers directly into their bloodstream.
Exactly.
The donor plasma will start attacking the patient's own organs and blood cells.
It's a completely inverted reaction. So, if O-negative is the worst possible plasma to give universally, what blood type makes for the universal plasma donor?
It would have to be someone who has absolutely zero bouncers in their plasma, so someone with type AB blood, because they wear both the A and B uniforms, so their body wouldn't make antibodies against either one.
You nailed it. Type AB is the universal plasma donor.
That is so cool.
Their plasma contains zero anti-A or anti-B antibodies. It is completely safe to give to anyone. It's a total inversion of the red blood cell rules, and it's exactly why blood banks are constantly begging for AB plasma donors.
Okay, if the biology is this unforgiving, like if a mismatch causes your kidneys to fail and your blood to simultaneously clot and hemorrhage, then the physical act of hanging that IV bag has to be flawlessly executed.
It has to be.
If I'm lying in an ICU bed, I want a supercomputer verifying that blood.
But the sources reveal a pretty shocking plot twist about where these fatal mismatches actually happen.
We all assume it's some deeply complex laboratory failure. Someone mislabels a test tube or misreads a chemical assay. But the hemovigilance data systems like the UK's SHOT program, which tracks serious hazards of transfusion, they repeatedly show that the leading cause of fatal ABO-incompatible transfusions is clerical error.
Clerical error? You mean like a typo? I mean, bedside identification failure.
Yeah.
The lab types the blood perfectly. They prepare the exact right unit. It gets sent up to the hospital floor, and the nurse hangs a correct unit of blood on the wrong patient.
Oh, my God.
Someone skips a step or feels rushed or assumes they know who is in the bed.
That makes all those annoying hospital protocols make sense. Like every time a nurse asks for your name and date of birth, even though they just asked you an hour ago, it feels like bureaucratic overkill. But that physical check is literally the only firewall between a patient and a fatal hemolytic reaction.
It is the ultimate safety net. And because human error is so prevalent, the Joint Commission mandates a rigorous, non-negotiable two-nurse check.
2 nurses every time.
Every time. 2 qualified staff members must independently, physically verify the patient's identity and the product's identity directly at the bedside immediately before connecting the tubing. They must match the name, date of birth, and unique medical record number on the patient's physical wristband against the printed label on the blood bag.
And if they don't match?
If there is a single typo, a single digit off, the blood goes back to the lab.
Then once they pass that checkpoint and the blood actually starts flowing, the tension doesn't drop. The protocols dictate that the first 15 minutes are critical, right?
Incredibly critical. The infusion must start at a very slow crawl, usually around 2 milliliters per minute. And the nurse cannot leave the room.
They just stay right there.
They must remain physically at the bedside, directly observing the patient for that entire first 15 minutes.
Because if the bouncers are going to attack, they're going to do it fast.
Acute hemolytic reactions or severe allergic anaphylaxis will typically manifest within those first few milliliters.
Okay, let's run through the ultimate bedside scenario. You're the nurse. You've done the 2-person check. The blood is running at 2 milliliters a minute. Suddenly, the patient spikes a fever, their teeth start chattering with chills, they complain of a sharp pain in their lower back, which I now know is their kidneys clogging, and they say, I just feel like something terrible is about to happen.
The impending sense of doom.
Right. What is the immediate response?
The very first step, regardless of what specific reaction you think is happening, is always the same. Stop the transfusion immediately. You clamp the line and shut off the pump.
Wait, you don't call the doctor to ask for permission. You don't slow down the drip to see if they stabilize.
Absolutely not. You stop the exposure to the foreign tissue. Next, you must keep the patient's IV access open because you are going to need to push emergency medications. You do this by running normal saline.
Okay.
But here is the critical detail that catches people off guard. You must completely disconnect the blood tubing and use entirely new saline tubing.
Wait, why can't you just hook the saline bag up to the existing tubing and just flush it through?
Think about the physical tubing. It is full of the incompatible donor blood. If you flush that line with saline...
You're pushing the bad blood in.
Right. You're physically pushing another 10 to 15 milliliters of lethal, unmatched blood directly into the patient's vein. So you disconnect the blood, attach fresh tubing with saline, and only then do you notify the physician in the blood bank.
That makes total sense.
And then the remaining blood bag, all the old tubing and fresh blood and urine samples from the patient goes straight back to the lab to figure out what went wrong.
Stop the blood, new tubing, run saline, notify the team. It has to be muscle memory.
Exactly.
But while you're executing that protocol, you also kind of have to be a detective, right? You have to figure out what kind of reaction is happening because the sources detail a massive spectrum of ways the body can fight back.
Yeah, we just described the worst-case scenario. The acute hemolytic reaction, where the red cells are actively rupturing. But statistically, the most common reaction a nurse will actually see is a febrile, non-hemolytic reaction.
Non-hemolytic, meaning the red blood cells are intact, they aren't exploding. So why the fever?
This is an inflammatory response. Blood isn't just red cells. It contains donor white blood cells too.
Oh, true.
While that bag of blood sits in a refrigerator for 3 weeks, Those white blood cells slowly die and release cytokines.
Cytokine.
Yet, cytokines are essentially inflammatory chemical messengers. When those messengers hit the recipient's bloodstream, they trigger the brain's thermostat, causing fever and intense chills. It's incredibly uncomfortable for the patient, but it rarely damages the organs.
Can we present that?
Yes, we prevent a lot of this today by using leukoreduced blood, physically filtering out the donor's white cells before storage.
Okay, so that's a fever from chemical messengers. What about anaphylaxis? I always associate that with like bee stings or peanut allergies where your throat closes up. How does blood trigger that?
It's an extreme allergic reaction, and it happens astonishingly fast, often after just a few drops of blood. We most commonly see this in patients who have a natural deficiency in an antibody called IgA.
Okay.
If they receive donor plasma that contains normal levels of IgA, their immune system views it as a massive foreign invader and triggers systemic anaphylactic shock airway constriction, plummeting blood pressure.
Wow. And the sources outline another massive diagnostic challenge for the critical care team. Two reactions that look almost identical at the bedside, but require totally opposite treatments. Cherry lye and taco.
This is one of the most dangerous showdowns in an ICU.
Mm-hmm.
A patient is receiving blood, and suddenly they are gasping for air. Their oxygen saturation plummets, their breathing becomes rapid and shallow, and they are in severe respiratory distress. The bedside presentation is nearly identical,
Right.
but the mechanisms are worlds apart. Let's start with taco transfusion-associated circulatory overload.
Based on the name, that sounds like a plumbing problem, like we put too much volume into the tank.
It is pure hydrostatic pressure. You've infused too much fluid too quickly into a patient whose heart or kidneys can't pump it effectively. This is very common in elderly patients or those with heart failure. The fluid basically backs up into the lungs.
Oh, I see.
It is essentially congestive heart failure triggered by the IV pull. The treatment is to stop the transfusion, sit the patient upright, and administer diuretics medications that force the kidneys to excrete the excess fluid as urine.
Pull the fluid off to relieve the pressure. That makes sense. But Troy transfusion-related acute lung injury is entirely different, and this mechanism absolutely blew my mind.
It's intense, yeah.
Because I assumed Troy was the patient's immune system attacking the donated blood in the lungs, but it's the exact reverse.
It is a devastating biological ambush. In TRALI, antibodies floating in the donor's plasma launch a targeted attack against the recipient's own white blood cells, specifically inside the tiny capillary beds of the recipient's lungs.
So the donated fluid is actively attacking the patient's lung tissue.
Exactly. This attack causes intense, sudden inflammation. The capillaries in the lungs become highly permeable. They start leaking plasma directly into the alveoli, the tiny air sacs where oxygen exchange happens.
So they're drowning.
Basically. The lungs fill with fluid, but not because of volume overload like in taco. They fill with fluid because of inflammatory capillary leakage.
Which means if a nurse misidentifies Troy as taco and gives diuretics to pull fluid off,
It won't work. Diuretics don't fix an inflammatory immune attack. In fact, giving diuretics to a TRALI patient can dangerously drop their blood pressure, which is already unstable from the systemic inflammation.
wow.
TRALI is a leading cause of transfusion-related death precisely because it is so hard to distinguish and manage at the bedside.
And just when a patient thinks they are out of the woods, the sources highlight that the danger doesn't magically vanish when IV is removed. You can have a delayed hemolytic reaction days or even weeks after going home.
Yes. This comes down to the immune system's long-term memory. It's called an anamnestic response.
An anamnestic response, can you translate that for us?
Sure, think of it like a dormant memory waking up. Years ago, a patient might have been exposed to a minor blood antigen, maybe from a previous surgery or pregnancy.
Right.
Their immune system built a few antibodies, but over the years, those antibody levels dropped so low that they didn't even show up on the lab's pre-transfusion screening.
So the lab clears the blood as a perfect match.
The lab clears it, the patient receives the blood, and they feel fine. But a week later, their immune system recognizes that minor antigen, wakes up from its dormant state, and rapidly manufactures a massive new army of antibodies.
Oh, no.
Yeah, they start destroying the transfused red cells weeks after discharge. The patient suddenly develops a fever, jaundice, and dropping hemoglobin at home. It reinforces why a nurse's job isn't just hanging the blood, it's educating the patient on what subtle warning signs to monitor long after they leave the hospital.
Zooming out from the cellular level for a bit, the sources also dig into the broader systemic and historical realities of relying on human donors. And some of those realities fundamentally reshaped how we think about safety. like the debate over the age of blood.
Oh, yeah.
Because we naturally assume fresh is better, right? I wouldn't want milk that's been in a fridge for a month, so why would I want 30-day-old blood?
That bias dominated medicine for decades. Clinicians argued fiercely that older stored blood was less effective and more dangerous. But large randomized trials, specifically the ADLE trial in 2015, put that intuition to the test. They compared fresh blood, which was less than 7 days old, to standard older stored blood.
And what did the data actually say?
The data proved the bias completely wrong. The older stored blood, up to about 42 days, proved to be just as safe and just as effective at carrying oxygen as the fresh blood.
That's amazing.
Is a crucial finding, because if hospitals were forced to only use blood less than a week old, the entire global supply chain would collapse.
Wow. But, not all historical biases in blood banking were just harmless clinical assumptions. The sources bring up Charles Drew again, and a very dark chapter in the 1940s involving the U.S. military.
Right. Charles Drew was the foremost expert on blood preservation, yet he resigned from his leadership role at the American Red Cross in 1942. He resigned because the military insisted on segregating donated blood by the race of the donor.
Which, based on everything we just discussed about antigens and bouncer antibodies, is just biologically absurd.
It is entirely devoid of scientific merit. A type O negative red blood cell is identical regardless of the donor's race. Drew protested because the policy was purely driven by social prejudice, and it really proves how easily systemic biases can attempt to override hard biological science.
And the systemic vulnerabilities of the blood supply became undeniably apparent in the 1980s, right, with the tainted blood scandals.
That was an unprecedented global tragedy. Before we had reliable scientific screening, specifically the ELISA test for HIV, which was introduced in 1985, donated blood unknowingly transmitted HIV and hepatitis C to thousands of transfusion recipients and hemophilia patients worldwide.
Just devastating.
The biological product meant to save them carried a lethal virus.
It makes you view modern protocols differently. Like, it explains why blood banking today feels like a fortress of questionnaires and advanced nucleic acid testing.
It completely restructured the field. The priority shifted to protecting the recipient at all costs, which led to incredibly stringent donor eligibility rules. It also heavily spotlighted the concept of informed refusal.
Right, a patient's right to simply say, I know the risks, but no thank you. The sources cite Jehovah's Witnesses as a major driver of this.
Yes, Jehovah's Witnesses frequently decline blood products based on religious principles, even when facing severe hemorrhage. And this presents a profound tension in medicine. The physician's drive for beneficence, the desire to save a life, clashing against the patient's absolute right to bodily autonomy.
How does the medical field respond when the standard protocol is just off the table?
It forced innovation. To respect patient autonomy without giving up on their survival, medicine developed incredible advancements in bloodless medicine.
Bloodless medicine.
Yeah, techniques like cell salvage, where a machine vacuums up the patient's own blood during surgery, washes it, and gives it right back. Or using synthetic erythropoietin to stimulate the patient's bone marrow to rapidly produce their own red cells. Necessity really drove the science forward.
If we look at this whole journey, it's staggering. We started this deep dive picturing physicians haphazardly pumping animal blood into people in candlelit rooms, and we've landed on this incredibly intricate, high-stakes modern science.
It's come a long way.
We've learned that whole blood is mostly a relic, replaced by precise component therapy. We've seen how the terrifying biology of bouncer antibodies means a simple clerical typo by a bedside nurse is the deadliest variable in the hospital. We've unraveled the mechanisms of tri-lie and taco and realized that, counterintuitively, giving less blood is often the safest medical strategy we have.
It is a profound evolution. And considering all those hurdles, the immense immune complexities of matching antigens, the constant threat of human clerical errors, the massive infrastructure required to screen and store human tissue, it really raises a vital question about the future.
Which is?
How close are we to an era where we simply manufacture synthetic, universally compatible oxygen-carrying fluids in a laboratory, bypassing the human donor and all these associated risks entirely?
Now that is a thought to chew on. From 17th century sheep veins to 21st century synthetic labs. Thank you so much for joining us on this deep dive into the source material. If you're lying in a hospital bed anytime soon, hopefully you have a totally new appreciation for the science, the history, and the absolute vigilance flowing through those IV lines. Stay curious, and we'll catch you on the next one.